Specialty Stories, session number 69. Whether you're a pre-med or a medical student, you've answered the calling to become a physician. Soon you'll have to start deciding what type of medicine you will want to practice. This podcast is here to tell you the stories of specialists from every field to give you the information you need to make sure you make the most informed decision possible when it comes to choosing your specialty. Welcome to Specialty Stories. My name is Dr. Ryan Gray, your host here. I used to say every week, but we've had some delays in finding physicians for the podcast. So I have a great guest for you today, and it was provided to me by a student. So if you have a physician, if you know of a physician who you think would make a great guest on this podcast, shoot me an email, ryan@medicalschoolhq.net. Look through our list, see what we haven't done, and remember, I'm doing academic and private practice / community for every specialty. And I only am looking for attendings, so no residents, no fellows, and no military physicians at this point in time. So again, if you have any suggestions for physicians who you think would make a great guest, email me, ryan@medicalschoolhq.net. Today I have Dr. Pamela Mehta, who is a private practice general orthopedic surgeon. Now, she's been out of training now for 10 years and has been in private practice for 2 years. So we get into a great discussion about what led her to private practice, what she's been doing post-training, what types of patients she sees, what she likes about orthopedics, and we even get into what it's like to be a female in a male-dominated specialty. We start by talking about what drew Pamela to orthopedics originally.
I didn't know I wanted to be a surgeon at all. In fact, I thought I was going to do primary care. That's why I went to medical school. That's all the volunteer work I did in college. And I saw myself as either a pediatrician or a family medicine doctor. And so when I was planning my third year rotations, I actually put trauma surgery first because I thought there's no way I'm going into this, and I just want to get it out of the way, and I want to practice how to, talk to residents and kind of how to impress attendings, and so that by the time I get to my family medicine, internal medicine, and pediatric rotation, I'll be in good position to get good letters, and I'll know what I'm doing. And so I was at USC for medical school, and they're affiliated with a large county hospital in Southern California. And at my first day of the trauma surgery rotation, I could not believe how excited I was and how just the adrenaline that was pumping when trauma came into the trauma bay, and how the ER doctors, the nurses, the surgeons, everyone worked together to get this patient up into the operating room as efficiently as possible. And I got asked, do you want to scrub into this surgery? And I was like, absolutely. And I scrubbed in, and I just will never forget that feeling. It was this ultimate adrenaline endorphin high that I was on. And we fixed the patient. We rounded on the patient the next couple days, and they went home. And we basically saved this person's life who had been shot through the abdomen several times. And from that day on, that first week, I decided, I'm making a complete switch. I'm going to do surgery. And kind of threw a wrench in my plans of having all my surgical rotations at the beginning to kind of just get them out of the way. So then I really had to just gear up and study really hard and just kind of make sure I got really good grades in those rotations. And then actually ended up being a blessing in disguise, because then I had the whole year to figure out what I was going to do my fourth year sub-Is in. Mm-hmm. And it gave me time to choose which surgical subspecialty I wanted to do.
Do you think it hindered you at all, realizing, quote unquote, that late in the game that surgery was what you wanted to do?
No, it didn't hinder me at all. And I know people get nervous about that and think they have to take a year off for research, and they have to go, get more letters of rec and just do a lot more. And for me, I was pretty steadfast that I wanted to complete med school on time in 4 years and start a surgical residency. And I just was really committed and passionate about it. And I just talked to as many people as I knew. And I think the best way to do that is at your own home program. That is your best kind of shot at getting a competitive specialty position. And so I figured out that I liked surgery on bigger things like orthopedics instead of like the eye or the ear. And I figured out also fast that I liked taking care of relatively healthy patients that just had one kind of issue or problem that you'd get this immediate gratification of fixing. And I really liked my orthopedic rotation. I thought the people that you work with are a lot of fun and smart and just kind of have a good kind of team mentality. And so as soon as I figured that out, I just kind of went forward pretty fast in terms of just doing as many rotations and preceptorships with orthopedic surgeons. And then I got into a little bit of research and just got really good letters. And I picked out my sub-eye rotations where I did away rotations my 4th year at some programs that I had read about that they accepted people that did rotations, and that was really important to them.
You finished your training 10 years ago. You've been out of training now, long before the hashtag I look like a surgeon movement, where female surgeons are out there saying, hey, like, I'm a physician, I'm a surgeon too. How much pushback was there, both inside and outside the system, for you as a female wanting to go into ortho?
I would say there is a fair amount of it. When I was at USC, I got told many, many times by the other orthopedic surgeons, the residents that I was on rotation with, why don't you do radiology or anesthesia or PM&R is a great fit for you because you like sports things. And I always I guess I never understood. I said, why? Why can't I do this also? And there was always this sense of, well, if you want a family and if you want an easier lifestyle, orthopedics is really difficult. And so once I got a position at a residency program, I will say I went to a very supportive residency, which is very important to kind of figure that out on your interviews. I went to Columbia, and out of the 6 people in my class, 2 of us were women, and the class right below me, 4 of them were women out of the 6. And we didn't have a lot of female attendings, but they were all very, very supportive, I think, because it was in New York City at a big academic center where they're very liberal about, women, obviously. And in New York City, most women work. And so I think I was almost protected there because I never really felt like a woman there in terms of like feeling discriminated against or kind of not taken seriously. Then when I went out into the workforce, that was the worst of it all, actually. When I started interviewing for jobs, I faced a lot of that. Well, are you going to get pregnant and stop working? And, oh, your husband's a spine surgeon, so why would you work? I got all kinds of ridiculous questions that are probably completely illegal. And that was, I had to navigate through all of that. I think that if you are a female and you want to go into a male-dominated specialty, you absolutely should, but you do have to have a thick skin. That's just, that's life. And you have to be able to let that stuff kind of roll off of you. And in some ways, you have to be even more perfect than your male counterparts, because if you slip up on something as a female, there are definitely that crowd of people that will think it's because you're a girl. So I do think you just have to develop a strong, thick skin, and you have to work that much harder, which I was up for that challenge, and I was okay with it.
Yeah. And we're recording this a couple days after the Southwest flight, in-flight emergency where the engine blew up. And, of course, it's a woman pilot.
A woman
that's landing
who saved the
so
day.
I was so happy to see that.
Yes.
That was awesome. So as a general orthopedic surgeon, what sorts of patients, what sorts of pathologies, injuries are you treating on a day-to-day basis?
That's a great question. I think part of the reason I loved orthopedics was because I can take care of children, young adults and seniors. I treat fracture work when, people who break their bones and have to go to the ER, they can't walk or, do the things they need to do, or sports injuries, shoulder rotator cuff tears, labral tears, knee meniscus, ACL tears. And then I take care of arthritis patients, the patients that are older that, need care for their joints. They can't walk. It's very debilitating. They can't play with their grandkids. They can't garden. They can't do the things that they want to do in their retirement. And so I do joint replacement surgery as well.
As a general orthopedic surgeon, the medical world seems to be going further and further into specialties and subspecialties. What led to the decision to stay a general orthopedic surgeon?
So that was also a difficult battle. At Columbia was extremely supportive of me during my residency. I do think that it was a little bit rare for a resident to graduate and not do a fellowship. So I think that my attendings would have preferred me to do a fellowship because everybody does do a specialty nowadays, especially in the more competitive environments in bigger cities like New York, LA, San Francisco, Chicago. I just decided I really liked general orthopedics. I liked the bread and butter orthopedics. I liked taking care of all kinds of issues, from sports injuries to fracture work to arthritic patients. And so I took the leap. I decided not to do one. I thought in my head, if I ever want to go back, I could do a fellowship. And when I applied for jobs, I actually didn't find it that difficult. I found that there were positions out there. And once you're in your job, you really learn so much on the job in your first couple of years as an attending and a brand new surgeon that the fellowship stuff doesn't really matter as much. Now, from a marketing standpoint, once you're out in practice, it probably is in your best interest if you are going to be in a bigger city to be able to market yourself as, I'm a sports specialist or I'm an arthritis specialist. So I sometimes kind of think, what would I have done if I did a fellowship? But I always come back to the same thing, that I really just enjoyed general orthopedics.
What led to your decision to open up your own practice, leave a hospital-based system, and come back and open up a private practice?
So this again kind of touches on that whole female thing. So I ended up joining a large group that had mostly men. I think I was probably the only female general orthopedist. I think there was a couple hand surgeons that were female or that are female. Once I had children, I have two young kids. One's 4 and one's almost 3 years old. I had them kind of back to back. Once I had my children, I realized that it was very difficult to work in a large group of men. They didn't always seem to understand if I needed to drop or pick up my kids, or if there's something going on at school, like a school play or something like that. And I just really wanted the flexibility to do what I want when I want on my own terms. It became a little bit harder to be able to do surgery starting at 7 a.m. in the morning because I have kids that need to be given breakfast and go to school. So I made the decision after my second child to go out into private practice, which was a difficult decision to make. I had a really good job with a steady paycheck and great benefits. And it's a little riskier to be out in private practice, especially on your own. But I felt like I had several years of experience in the surgical volume under my belt that I felt confident enough to go out on my own. And now I've been out on my own for about 2 years, and I'm happier than ever because I am my own boss and I call the shots. And if I want to start clinic at 9 or 9:30 in the morning, I can. And if I want to do cases at 10 a.m., I can. And I am probably busier than I was before, but it's all on my own terms. And financially, I probably make more money than I did before as well. So I'm very happy with my decision to do private practice.
That's awesome.
Thank you.
For the students out there that love the investigative part of being a physician, as an orthopedic surgeon, what percentage of your patients are coming to you already diagnosed and you're just booking them for the OR, or how many are coming needing that diagnosis to figure out what's wrong with them?
Oh, that's also a great question. I would say mostly everyone comes that still needs a diagnosis and that needs kind of some fact-finding. I often have patients that have been either to their primary care doctor or a chiropractor or a physical therapist, and they have some kind of lingering pain in their knee or shoulder, but they don't really know why, and so they haven't even had x-rays done, let alone MRIs. So oftentimes they're coming with some idea of kind of what may be going on, but they don't have the answer yet. So I would say that mostly we have to diagnose the patient, so we take them kind of from beginning to end. And in orthopedics, there's a lot of non-operative care that you do before you actually do any kind of surgery. So I think that's interesting too, because you kind of get to see them through that whole pathway and see when patients are getting better without surgery, or whether, now's the time to pull the trigger and it is time for surgery. I would also say that because orthopedics is not a big part of medical school, I think when I was a second year med student, we got like 3 or 4 weeks of musculoskeletal, and then in your rotations, it's not required. So many people don't even do it. that unfortunately a lot of primary care doctors don't really know how to diagnose some of these problems. So I'll have patients that come in that are diagnosed with like carpal tunnel syndrome in their hand, and really what they have is a trigger finger. So I think in some ways it's almost more complex because sometimes you're being led in a different direction from like what says on the referral than when the patient comes in, and you kind of have to start from the beginning and not really trust anyone else's diagnosis, not because they're not smart or don't know what they're doing. It's just they haven't had the training in it.
Mm-hmm. For the future primary care doc out there, is there a general reference manual that you love to tell primary care docs to get?
So the fracture handbook, it's a really small handbook that you can put into your pocket. I like that for fractures. I think that's really good. And then I don't really have a good one for just kind of general bread and butter ortho. I think that if you have like the opportunity, even shadowing an orthopedist in some point in your training, in your residency training, I think it's super important because so much of what comes into your office is musculoskeletal. It's surprising.
Definitely.
And then I really have tried as a private practitioner to go out in the community. I give my cell phone, my email address to all the primary care doctors, and I tell them, if you have a question, you need a curbside, just text me, call me. I'm more than happy to walk you through things and answer any question for you. So I think building a relationship with an orthopedist in town as a primary care doctor is a good idea too. Just someone to pick their brain and kind of ask, like, is this something that's serious? Is it not? Can it wait till after the weekend? That sort of thing.
You talked about there's a lot of non-operative stuff that happens before you take somebody to the operating room. What percentage of patients do you think that see you actually end up taking to the operating room?
Oh gosh. Okay. So when I was working for the large group, I would say that it was probably 70% went to the OR because there was a lot of layers of primary care, physical therapy, PM&R that was seeing the patient before they finally got to me. If you are out in private practice, and I would say that might be the same of academics as well. Mm-hmm. I think if you are out in private practice, then that percentage is very different. You're probably taking 30 to 40% of those patients to the operating room. And that is because as a private practitioner, you don't ever really want to say no to anything that comes through your door, because if primary care Dr. Smith is sending you just routine knee pain, you want to take care of that patient and also get their I tore my rotator cuff patient. So you never say no. You see everyone and everything. So you're less protected when you're out in private practice and not part of a large multi-specialty group.
Yeah. Describe a typical week.
So now that I'm out on my own, I can do whatever I want, and I have decided that Mondays I like to operate. So Mondays are my OR day, and I like to start the week off with that. And I also like to start the week off with that because I do a fair amount of outpatient surgery, but some of my surgery is inpatient, like my joint replacement. So if I do them Monday, then they're out before the weekend, which is always nice for the patient and for the doctor. And then usually Tuesday to Friday, I'm in the office, and it's a mix of procedure work, meaning giving injections. I do some regenerative medicine like PRP and stem cells. And then sometimes kind of closer to the end of the week, Friday or Thursday, I'll do a second OR slot where I'll take some fractures that have come through on call or on through the ER, or have walked in the clinic. So that's usually what my week looks like. When I worked for this larger organization, I was probably in the operating room closer to 2 full days of the week.
As a private practice orthopod, how does call work? How do you get involved in call with the hospital?
So when you are in private practice, you decide to affiliate yourself with certain hospitals, and usually those hospitals will ask that you take ER call, meaning that you're on call a few nights of the month, and the ER will call you with any fractures that come through. And usually when you're brand new starting out, you want to take that ER call because that's how you get some patients into your office. And then, inevitably mom who broke her wrist will tell her friend when her friend has knee pain. And so then that becomes a referral source for you as well. So that's ER call, and you can do as little or as much as you want usually. If you're part of a group in private practice, or even like me who's a sole practitioner, you will join up with some other colleagues and take group call for your private patients that come through your office. So, if my patient has surgery on a Thursday or Friday, then over the weekend, if that patient is having pain or questions, then they'll have somebody to call. So I am part of a larger call group for those patients that come into our office. It's about 8 of us. And that's pretty light. That's not anything too crazy. I think it becomes a little bit more work intensive if you are affiliated with a large trauma hospital where you're in-house doing a lot of fracture work overnight and things like that.
Do you feel like you have enough time for family?
Oh, yes, I do. I have too much time for my crazy toddler boys, actually. So my husband's a surgeon too. He's a ortho spine surgeon. So I think there's some balance that comes with that. And so we kind of work together in terms of what our week is going to look like, who's going to be in the OR what day, and who's going to be on call, and when will we get out of, clinic and be able to see our kids. But I would say that, the most important thing is when we come home, we're there 100% for our children. We put our phones away and kind of disconnect from the rest of the world, and we're playing and doing things with our kids till they go to bed. And then we really make weekends about family time and making sure we, do things with them, take them up to San Francisco, go for hikes, spend time with family. Our kids are in soccer in the morning. So I think we have a really good work-life balance, which I think that is also in part due to my partner. I mean, he's all about doing 50% of the household work. So I'm very lucky that way. So I think that's super important.
Talk about the path to become an orthopedic surgeon. What does the training look like?
Obviously, 4 years of undergraduate training and then 4 years of med school. And then usually in your end of third year, beginning of fourth year, you have to do an orthopedic rotation, usually at your home program. And then you can make the choice to do a couple sub-Is away. And then I applied probably to about 10 orthopedic programs, and I went on about 6 or 7 interviews and matched at Columbia, and that's a 5-year program. All orthopedic residencies are 5 years. Your first year is a mix of general surgery and orthopedics. And then PGY 2-year is basically what we call our ortho intern year. So you're kind of the scut monkey and you do all the consults in the emergency room. And that's probably your most work intensive year. And then the rest 3 years are basically more concentrated on operating and operative skill. And then people can choose to do a fellowship, and all orthopedic fellowships are 1 year, which is really nice because that's actually not long. And the fellowships are spine, sports, joint replacement, hand, foot and ankle, and peds. Yeah.
Ortho's pretty competitive to match into. What should a student be doing to make sure they are competitive enough to match?
That's a good question also, too, because I feel like I was intimidated by how competitive everyone said it was, and it is a very competitive specialty. I would say first and foremost is try to honor your rotations in your third year. They look at that, and to try to get good letters of recommendations and score well on your boards, although I will say I had pretty average board scores. And even when I got those board scores back, many people said, oh, you might need to take a year off and do some research, or maybe you need to switch gears. But I was pretty determined, so I picked 3 places to go do my sub-Is, my 4th year, and I just busted my butt. I was up first in the morning. I was the last student to leave, and I just made a really good impression on those people and was able to garner a couple more letters in that process. So what, and I did a little research. I wouldn't say my research was very heavy. So what I would tell the student is that if you have good board scores, that doesn't make you a shoo-in for sure, but it does help your chances quite a bit. But if you don't have good board scores or just kind of mediocre ones, then it's that much more important to just impress people a lot and get really good letters.
The osteopathic world is growing and growing, and there are a lot of osteopathic students who are very interested in ortho. What sort of negative bias do you see against osteopathic students in the ortho world, and what can they do to potentially overcome that?
So I actually see none. One of the best orthopedic surgeon in that big group that I used to be a part of was a DO. He operated better and more efficient than any of the rest of us. He was probably the most revered. Everybody asked him when they had questions about things or needed to go over a case. I currently work with an orthopedist in town that is also just excellent. He's very, very well trained. So I really think that we're at a time now where there's really not much bias that I can see, and I think just kind of put your head to it and persevere. And I think that once you actually are out in practice, I really think it doesn't matter that much at all.
Yeah, there's still a few figureheads at some of the more prestigious programs that probably have some bias, but outside of that,
you know what? Then that's not a program you want to be a part of. Is what I've really learned to figure out is that any place that is that unaccepting, whether you're a female or you have children or like you said a DO, then that's not really a place that you want to be at. And I think the quicker that people learn to realize that, I think the better, because I think we all somehow get caught in, we got to be at the best place with, if they don't want you, it's okay. You'll just work harder, but unfortunately doesn't work that way. And I think that it's best to be at a place that's going to support you in your endeavors.
Yeah. I think you kind of already answered this with physical exam skills, but I'll ask anyway. For the future primary care provider out there, what's the one thing you wish they knew more what you do day in and day out to help you and your patients?
You mean the primary care physician?
Yeah.
I think that the biggest thing I can say is that if you're going to send a patient to me, at least have x-rays done. It's very hard in orthopedics to evaluate patients without x-rays. So I think that's important. And then also, you can always get someone started on physical therapy, unless it's a broken bone. I think that if somebody's having knee or shoulder pain or any extremity pain, you can get them going on some physical therapy. So it's kind of nice to just knock out a few of the non-operative treatments before sending them to a specialist. We use a lot of NSAIDs. We do the PT, and then if a primary care physician isn't comfortable with an injection, I totally get that. I'm more than willing to do that for the patient, but kind of just making a little effort to get them a little bit of treatment before they get to you.
What other specialties do you work the closest with?
Surprisingly, pain management. They're a big one because usually you'll get patients with back and neck pain, and pain management can help a lot with that. And PM&R as well. But then after that, probably internal and family medicine.
Are there any special opportunities outside of clinical medicine, seeing patients in the clinic, for general orthopedists?
Yes, there's actually a ton, to be honest. There's the whole medical legal world where people ask for you to review charts and do kind of, and this isn't just for insurance companies, but also for people who get into personal injury. They get into a car accident, things like that. Those injuries are almost always orthopedic in nature. So there's a lot of personal injury work that you can do. It can go from the whole gamut of doing an independent medical examination, or you could be an expert witness, or you can be a treating physician for the patient, or you can review charts. There's a lot of work that you can do on the outside of just clinical medicine in terms of dealing with traditional insurance companies. And I think if at some point you decide to transition and just wanted to do chart reviews, you could probably even make a whole profession out of that. And then what's also nice in orthopedics is we cover a lot of sports games. So you can go to the local high school and junior highs and community colleges and ask if they need someone to come and kind of be there on the sidelines for the games. And so you can get patients that way. And also it's just kind of nice to be at those sporting events and to take care of people that way as well.
What do you wish you knew, or what do you know now that you wish you knew before going into ortho?
Oh, it's again back to that female thing. I think I was really naive and energetic in medical school, thinking, oh, it's not a big deal that I'm a female. And even if some people are a little bit hesitant about it, it'll be okay. And for the large part, it has been, but I think at some point it would be nice to have more female colleagues instead of all men colleagues all the time. And also I just feel like I'm a little bit out on an island because there's only about 5% of us female orthopedic surgeons practicing outside of residency. I think in training it's about 14%, and then we drop down to 5%. So there really aren't very many of us. And so I think sometimes that's a little bit of a struggle, and just not feeling the camaraderie that I think in more female-dominated specialties like maybe OB-GYN or pediatricians, when they're starting a family, I think they get a little bit more support from their colleagues than I do as a female. But probably that would be it. In terms of the actual work, I absolutely love ortho, and I would not be happy doing any other field. I really like it. And that being said, I do think when you're in medical school and maybe one specialty isn't working out for you, say, you've gotten the feedback that you're not going to match into this specialty, or you have tried to match and you don't match, I do think it's a good idea to keep an open mind to think about 2 or 3 other different specialties, because I really do feel like you can be as happy in those as you would be in the original one you chose. So now at this point, I can't see myself doing anything else, but back then I probably could have, yes.
How do we fix that? The 14% in training, 5% out in practice of female orthopedic surgeons, is that a system thing, you think, keeping numbers down, or is that the stereotype of the orthopedic surgeon being this male sports jock Neanderthal dude? How do we fix that and let women know that yes, you can be an orthopod?
Yeah, it's a system problem. Unfortunately, there's still a lot of discrimination in medicine, and probably more so in the surgical field. And then if you even narrow that down, probably more in fields like orthopedics and neurosurgery and urology. It's unfortunate, but we just haven't made the strides, that we should have made by now. So I would just say that the way to do it is for the men to really accept females into their quote unquote circle, and just recognize that we're a large part of the workforce. We have something to contribute. And just like we all know that it's good to have different, diversity in fields, that, we need that in orthopedics as well.
Yeah, there's plenty of data out there that shows that when women are in charge of companies or have lots of leadership positions, that those companies do better.
Yeah, I mean, there's not one thing I've ever not been able to do that a male counterpart of mine has been able to do. And I think that's proved time and time again. And I think what concerns me more than the 14% is the 14 to 5. So where are all those females going? Where did they go after they trained for 4 years of med school and 5 years of residency and maybe a year of fellowship? How come it drops down so significantly? And I would venture to say that is probably because that's around the age that people start a family. And if people in the workforce aren't more open to that females are the ones that are bearing the children and have to kind of stay at home a little bit more with their kids, or work part-time or even semi-part-time, that's something we need to accept, and that we need to nurture that. I mean, and I think that is a scarier number to me than the original number, because you've gone through that much training and you just stop working. That sounds odd to me. Why would that be?
Yeah. What do you like the most about being an orthopod?
I like the variety. I think that's what I've always liked about it, and I still think that's what I like about it. I like that I get to go to the operating room. I like that I get to have my day in the office. I like that I can do some procedure stuff with injections and things like that. I even like, after all these years, casting a distal radius fracture. I love all of that. So I just like the variety, I think. And I get to do big surgeries where it's open and I'm fixing things with plates and screws, or putting in a total joint. And I get to do smaller surgeries like, scoping a knee or shoulder, just like playing video games. So it's great. What
do you like the least?
Oh God, in every surgical field, you hate infection and pus. So that's probably the thing I dislike the most.
Yeah, an infected joint is not a fun thing.
Oh gosh, please, I get shivers.
Do you see any major changes coming to the field that a student should be aware of?
I think orthopedics is a very dynamic field, that there's new stuff coming all the time. I think we're improving all of our implants that we put in, the plates, the screws, the joint replacement surgery. And then there's a huge wave of regenerative medicine with stem cells and the different ways to garner those stem cells. So I think there's a lot on the forefront for orthopedics.
If you had to do it all over again, would you still be an orthopod?
Yes, I would. I think I would be less naive about being a female in ortho, but yes, I would do it. I would do it all over again.
Any last words of wisdom for the medical student out there thinking about ortho that you can give to him or her?
Yeah, I think it's a great field with a lot of variety. You get to operate, you get to see patients in the office, you get to have fun with your colleagues. For the most part, we're all a fun group of people. And, you get to treat patients that really want to get back to their active lifestyle, which is nice. And for the most part, they're generally healthy. I think if you're a medical student that's struggling a little bit with maybe board scores and things like that, don't let it get in the way. You can do it. It's very possible to do it, and even without taking time off. I think it's just super important to show your passion and dedication for the field, and just work really hard, and you can absolutely achieve anything you want.
All right, there you have it. Again, that was Dr. Pamela Mehta, general orthopedic surgeon in private practice. Great conversation about being a woman in male-dominated specialties and so much more. Hopefully that was helpful for you. If you were interested in orthopedics, if you're a woman and interested in going into a surgical subspecialty, hopefully this has opened your eyes to some of the potential challenges that are out there, unfortunately, for you in the future. Hopefully things get better. That's the goal here at this podcast. We've done some, if you were interested in that discussion on the pre-med years, we've done some discussions with other female physicians and trying to figure out how we can make medicine more open to female physicians and physicians who want to go have babies and don't have issues with that from the male colleagues. So hopefully that was helpful. Go check out those pre-med years podcasts if that was interesting to you. And again, if you have any suggestions for specialists for this podcast, again, not just the specialty, but if you know a physician who would be a good guest, shoot me an email, ryan@medicalschoolhq.net. Hopefully I will see you again soon. Have a great week and take care.